I have to say, what a kind of a humbling opportunity to be here speaking about early detection and intervention, sort of in, together with friends and colleagues who have really led the field in this area. It is amazing being at the Mind Institute, and I'm really looking forward to the panel discussion. I remember the earliest Baby SIB Consortium meetings with both Sally Ozenoff and Sally Rogers, and it's amazing how far the field has come and how far we have to go. I mean, special thanks to David for being such kind of a wonderful organizer and host. Thanks and congrats to Aubin, and what an inspiring overview of the Mind Institute as well. And thanks to everyone who's been so welcoming today. So I'm excited to speak about this topic. So brief disclosures in terms of sources of funding, as well as sort of my personal role in both our observational measure and to some extent supporting the development of our intervention measure. I mean, it is important to acknowledge sort of the biases that that might relate to sort of having that sort of investment and kind of direct role in a particular tool. And it's probably important for me to acknowledge some of those administrative roles as well, because I think working sort of with community pediatricians, sort of having responsibility and sort of understand, kind of some sense of the demands that community physicians face, I think has probably shaped the way that I think about some of these issues. And again, I feel very privileged to have a chance to talk about some of our group's work in this area. I really want to acknowledge the enormous contributions, both of my friends and colleagues at the Mind and throughout the field, and we have made a lot of exciting advances. I mean, the focus of the talk will be on sort of the earliest signs of autism, and I think that probably as importantly, the diversity of presentation, sort of recognizing the diversity among autistic children and autistic people throughout the lifespan. It's not surprising that there's variation in sort of what the earliest signs might be and sort of how those signs might evolve over time. Thinking about implications for the diagnostic process so that we're sort of flexible and adapting to that diversity, and also thinking about how do we make that process more equitable. And from that perspective, kind of thinking about our assessment models and community partnerships, and being aware that continuing to push towards earlier and earlier identification doesn't necessarily translate to earlier diagnosis or better well-being for autistic kids and families. I think that, I feel like in almost every autism-related research talk, it is important to talk a little bit about positionality and use of language. So I'll try to ground it in sort of the particular focus of the presentation, but I think it sort of touches on broader issues. So the lead author of this commentary, who actually trained at the Mind Institute, Patrick Dwyer, is one of a group of autistic researchers who published a few kind of one of a few commentaries in this field. I like the emphasis kind of both coming from living experience and sort of how it was framed, and this notion of thinking about how we sort of choose our vocabulary in a way that sort of really reflects cultural humility and willingness to learn from autistic people, not just about autistic people, sort of about their sense of identity, sort of how they see themselves and the field, and ensuring that our language in particular does not undermine their sense of self and well-being. There has been a lot of back and forth discussions, sort of both informally in rooms like this and sort of through the literature, a kind of a somewhat tense discussion, and sort of, I think, at the other end of the continuum, there's been some researchers that have pushed back on this notion of a particular set of vocabulary because it might constrain kind of scientific dialogue, undermine our ability to speak sort of with precision, and this notion kind of even academic censorship that we have to be so careful about our selection of words. I mean, I have to say, sort of working as a clinician and as well as in a research context, I feel like respectful communication is not censorship. And, I don't think that we can ever be prescriptive. I mean, I think we all have to respect our colleagues' autonomy and recognize and respect their choice of words. I think at the same time, we have to recognize that our choice of words is not without consequences, and that first do no harm is actually an important principle to keep in mind. I think sort of from the first time that we connect with families, that the words that we use kind of stay with them for a lifetime. lifetime. So our ability to convey a sense of hope and positive regard and sort of kind of optimism about the future, I think can actually be a very powerful tool. And that there is a power imbalance sort of kind of within sort of whenever we're working with autistic people and families, and I think we have to be very cognizant of that. I think today is also a reflection that we really don't communicate in silos. Like, it's not realistic to think that we can communicate with our research colleagues using one set of words and within society with another set. I think those barriers are broken down. I think it's actually a really positive development that autistic people and families are participating in the research process, engaged. It's not sort of different tracks. We're all in this together. I think about the medical students and the pediatric residents I work with, and the truth is we actually do a better job clinically when we use neutral descriptive language, so that we're really clear what we're talking about rather than sort of always filtering it through a sense of evaluation. It also allows families to tell their stories, sort of the strengths as well as the challenges, and sort of kind of open that door to a more holistic approach. And so all that preamble to say that, sort of like some specific choice of words. For instance, I'll use increased likelihood rather than high risk. I mean, risk is an epidemiologic term, but risk, I think in some circles, implies that something bad is going to happen, so we'll stick with increased likelihood. And I'll also use identity-first language. I realize that there isn't a universal convention about that, but I think sort of feedback from autistic colleagues and others with living experience, I'll tend to kind of go in that direction. Okay, so as to say, so why does this whole area of research matter? I think it's an attempt to make a respectful response to parents who have kind of been the trailblazers in this field in terms of recognizing the earliest features of autism. I think for decades we've recognized that parents are mostly the first to recognize the earliest signs, not uncommonly even in the first year, but we know that diagnosis doesn't take place until years later. We also know that there's a lot at stake in early identification in terms of the opportunities to provide supports and services and interventions. And I think increasingly, and I think really exemplified in the outstanding work of Early Start Denver model as well as the Infant Start, it's not about making a categorical diagnosis. It's really recognizing the functional differences that lend themselves to kind of providing support and supporting that trajectory. Sally and I think David alluded to the baby sibling, and Aubin actually referred to the baby sibling studies. So, for the past 25 years or so, we've been fortunate that families have sort of let us into their lives. They've come and visited our labs, and to in some context sort of invited us into their homes through telehealth. And the whole notion of it is that because autism can run in the family, siblings are more likely to develop autism than children that don't have an older sibling with autism, and therefore we can have the opportunity to sort of observe as the earliest features emerge. It's a research approach that was used in other areas, but particularly is well suited to autism because autism is a condition where the features can emerge in infancy, and that we can be fairly confident about the diagnosis sort of in the first 2 or 3 years of life. I think there's an important caveat to that we can diagnose some children, but not all, and I think we're becoming increasingly cognizant of that. I think another advantage that we don't often think about is that the children that we see in the clinic, they don't get there unless someone in the community has kind of listened to families and sort of identified a kind of a reason for referral. So often that sort of restricts the profile of the kids that we're seeing. So those kids that end up getting diagnosed at 8 or 12, we don't get to learn a lot about sort of early features because they don't really come to the clinic before 8 or 12. But sort of by working with siblings, we get a chance to see them and monitor the development sort of regardless of whether someone in the community has made a referral. And to some extent, it gives us an opportunity to assess early signs kind of across that continuum. And of course, most importantly, we can be thinking about intervention, not just hypothetically, kind of in a 5-year-old, like what might have been possible if we'd had a chance to see them at 6 or 12 months, but sort of in real time. And I think that's led to important advances. And this is a group that is genuinely at increased likelihood. So this is work that Selye-Ozanoff has led with Greg Young and the Baby Sib Consortium. In a paper that was published earlier this year, the overall rate of autism in these younger siblings is about 1 in 5, or 20%. I mean, it's interesting that in the time between when this paper was published and an earlier paper 13 years ago came out, sort of as the overall population rate of autism has increased quite substantially, the actual recurrence rate has actually remained relatively similar. So it was like 18.7% 13 years ago. I think what is especially striking, though, is that in that earlier paper, the ratio of younger brothers versus younger sisters being diagnosed was about 2.8 to 1, whereas in this recent paper, it's about 2 to 1. And that suggests that we're slowly learning about how to identify the earliest signs of autism in girls and actually make a diagnosis kind of in those preschool years. It's an exciting time. Not only are we learning about the early behavior features, but because we're working with infants and families in real time, there's an opportunity to draw on technological advances, work in imaging and genetics and biomarkers, and sort of increasingly technology-based kind of computer-aided approaches to assessing and quantifying some of the early and subtle differences that might bring us closer to earlier and earlier detection, as well as improved approach to intervention. However, most of this work has actually been focused on younger siblings. Increasingly, it's extended to other groups of infants who are at increased likelihood of autism because of some specific medical condition, like a genetic diagnosis. But it hasn't really translated into the general community. And although there are some population-based studies of early features of autism, they're often sort of a bit of an add-on to kind of an existing population-based study of development. So the measures tend to be fairly general than autism specific. As well as they also tend to be at urban centers, and they don't necessarily reflect the diversity of the population of kids and families that stand to benefit from this work. I think as there's an increased focus on sort of kind of biologically and technology-based measures, there's the possibility of like pushing the envelope of earlier detection, kind of beyond when we're actually able to observe overt behavioral differences. But it's important for us to keep in mind that that sort of pre-symptomatic detection is not equivalent to early diagnosis, and it kind of shifts the discussion. It's one thing to be identifying early developmental differences, but sort of just increased statistical likelihood because of a difference on a brain scan or a subtle difference that's picked up through machine learning doesn't necessarily provide guidance in terms of what we can actually offer that family in terms of supports and strategies. Our group, and I'll show you a photo in a moment, got together to kind of take stock of our work together, sort of what we've learned, but sort of how much farther we need to go. And not only about characterizing the earliest signs of autism, but actually making sure that this translates to earlier diagnosis, kids getting intervention services, and ultimately kind of thriving in a different way than if we hadn't recognized the early signs. 4 sites in Canada. Again, proud to be part of the Baby Sib Consortium, which includes many other international sites. Kind of over a period of about 20 years, we had the opportunity to work with about 500 families who had an autistic child, and then we worked with the younger baby in the family, as well as a group of families that were very generous with their time, also participated in this longitudinal work, even though they didn't have a particular family connection to autism. There are a range of measures in the study. The ones that I'll focus on specifically today are interactive measure of early features of autism that Sally alluded to, some kind of general developmental measures, general language and nonverbal learning, as well as adaptive skills. And I won't talk as much about behavioral differences, but sort of happy to share more at the panel. The approach to the study is that the kids came in starting at 6 months. They were followed at regular intervals. If they met criteria for diagnosis at any point, we provided a diagnosis, but sort of by design, we had an assessment at age 3 where a clinician came in who hadn't met the child or family before, didn't know whether there was an older sibling or not, and sort of did a comprehensive of assessment, and including kind of the standard measures in the field, and then kind of shared their diagnostic impression kind of independent of what some of the early assessments showed. And this is our group. And in fact, we had realized we had been at this for 25 years, so it was kind of our silver anniversary. And it was a very special meeting because the co-lead investigator, Susan Bryson, who's seated in the center of the photo, who had some health issues and hadn't been as involved the last few years, participated in the full meeting. And this presentation really reflects her life work and her passion for this area. You know, I met her when I was a pediatric resident and just starting my developmental training. She had this brilliant approach to thinking about early development in autism. Her particular focus was early attention, and particularly the flexibility of attention. I was just coming at it as like kind of a green pediatric resident, wondering like, well, why aren't kids being identified in physicians' offices? And like, what should we be telling physicians to watch for? So we got together, wrote a first grant, and now we've got this wonderful team and this body of work. In terms of our observational scale, we were motivated to develop it because there were great measures in the field of different aspects of autism, like social communication, but there was nothing that quite covered the range of early features. So we drew on what parents kind of described looking back at the first year of life, sort of drew on some experimental measures. So there's an item about response to facial emotion that's kind of a simplified version of the full face, still face procedure where the examiner is interacting with the infant, and then they sort of go to a neutral face and you're kind of looking to see sort of how the infant reacts. And then broadly, we tried to cover the range of diagnostic features as well as other relevant areas of development, like motor development as well as reactivity. You know, Susan published the original work on the psychometric properties, showing that it had good test-retest as well as inter-rater reliability. My colleague Annette Estes, as sort of part of her role leading the behavioral component of another large infant study, looked at the agreement between kind of coding the measure in real time in person versus coding from video. As I mentioned, our 3-year assessment involves a clinician who hasn't met the child before, but we couldn't quite figure out how to do that at the earlier assessment. So we've always been a bit worried that the examiner, when the babies were younger, was a bit primed to be looking more carefully for signs of autism, especially if they knew that the child was a younger sibling. So it was reassuring that, you know, even someone looking at those early assessments from video where they didn't know sort of whether there was a family history, kind of the way they coded the measure was still very similar to how it was coded in real time. And it's also reassuring that as a number of other groups have used the measure, they're finding sort of very similar predictability in the sense that sort of the early features that were predictive or sort of kind of meaningful early on and sort of anticipating later diagnosis, they're finding very similar findings. And interestingly, not only for younger siblings, but also children from other medical groups like children with Fragile X syndrome or tuberous sclerosis. So here's like the kind of the overall bottom line. So if you look at the total score on this measure, sort of over the period of time that children are coming in for visits, or at least the period of time that we're administering the AOC between 6 months and 18 months, if you divide the group of kids into the group of siblings who ended up developing autism, the group of siblings that did not end up developing autism, and then the other infants who didn't have a family history, you know, it's even in the first kind of 6 to 9 months, there's a difference between the sibling group and the non-sibling group as a whole, but you don't really see a difference between the siblings who developed autism versus those that didn't until about 12 months. And very similar findings across other groups that have used this measure. For the most part, kind of this is just kind of a summary of kind of the effect sizes. So it's pretty close to 0. So kind of largely no differences when you add up the scale. If you look at the individual items, it's interesting that the one item that distinguishes the infants who were diagnosed with autism from all the other infants, including the other younger siblings, was actually motor control, like whether they could sort of sit stably, sort of the quality of their reaching behavior. So not part of the DSM, but certainly something that parents have commented on. And I think sort of families of older kids as well as therapists recognize sort of the relevance of motor development in autism. And then I've just sort of added here this idea of familial features, sort of what distinguishes the sibling group as a whole from the infants who didn't have a family history. And there were some kind of both social differences and differences in behavioral reactivity. And again, this is not a completely novel finding around differences in early motor development. Rebecca Landa's group and her colleagues sort of reported things like head lag and truncal stability, sort of finding differences at 6 months. There are findings from Sally Ozanoff as well, sort of looking at, I think early home videos at 12 months. And there was a paper from the Baby SIB Consortium sort of looking at the details of a comprehensive developmental measure, the Mullen, sort of finding that the fine motor scores at 6 months were actually predictive of kind of the autism symptom measure, the ADOS at 3 years. Very different at 12 months. There are really pronounced differences on the scale as a whole in the infants who develop autism versus those that don't. This is my colleague and friend Jessica Bryan in her wonderful way of doing assessment. She leads the Toronto side of our study as well as the intervention arm, which I'll speak about. And this is a list of the specific features that distinguish the infants who went on to develop a diagnosis of autism versus those that didn't, both from the sibling group as well as the other infant group. And they broadly map onto how, sort of how autism is described and also the kinds of features we look for in older preschoolers. Not responding when name is called, reduced eye contact, kind of reduced kind of sharing, joyful kind of facial emotion, and then some of the sort of the second area of features, so difficulty shifting between activities, getting sort of focused on a particular activity or object, seeing sort of kind of distinctive sensory interests, and in general sort of like a small group of kids, but sort of really distinctive who are who may get so preoccupied with a particular object or activity that they're not as actively kind of visually exploring their environment. I want to kind of show you a couple of videos just to give you a sense of kind of what this looks like at 9 and 12 months. This is, and both of these children, we had the chance to meet them because they have an older sibling with autism.
Raylyn. Oh. Raylyn. What you got there, sweetie? You got everything. Oops. Yeah. Raylyn. Raylyn.
So really illustrating sort of both the lack of response to name, but I think sort of like some of the other aspects of how she's engaging and how she's kind of sharing her interest and enjoyment, sort of like kind of that sort of reduced variability in her facial expression. Something that parents kind of describe that, the sort of just the difference in emotional feedback sort of early in life among some of their infants who go on to the diagnosis. This next video is intended to show some of the motor differences, but I think you'll see some of the social differences as well.
1, 2, tickle! Here comes a tickle monster. Ah, tickle, 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 tickle. Here comes it tickles. Gotcha! The tickle monster gotcha! 1, 2, 3. Did that tickle monster get ya?
So in that video, I mean, the intention was to show both the social differences and some of the kind of repetitive motions. I have to say, I've shown it to some of my community pediatric colleagues, and the thing that they've commented on is, well, she's making eye contact and she's sharing a bit of smiling. And it really sort of exemplifies how, so first of all, this is all on a continuum. You know, we can't be suggesting to professionals that it's an absence of this, it's a lack of this, that even children with sort of like for the trained eye, the most kind of, evident features of autism, there are going to be some strengths. There invariably there are differences in sort of how kids respond to social opportunities and their ability to kind of initiate socially. And I do think that pediatric, the response of those pediatricians really does emphasize sort of what a difficult environment it can be for some families. That there's this kind of sometimes narrow notion of autism and sort of this kind of inclination to conclude, they're too social. She's making eye contact momentarily, therefore it can't be autism. And we have to sort of think about how we incorporate that into what we teach. As I said, one of the limitations, particularly of our work, is it's been like a pretty exclusive focus on younger siblings. And we've just gotten some funding to open it up to kids in the community, like to, separate from the Next Gen study that Aubin mentioned that focuses on basically younger nieces and nephews of autistic individuals. So, a sibling has had a new child. Now we're going to invite, if there are families of 6 and 9-month-olds are concerned, we're really interested to see sort of how the AOC will perform and whether it will add information over and above sort of general clinical impression and what parents are describing. And this is kind of these are called ROC curves. It kind of gives a sense of sort of the accuracy sort of over the sort of the range of scores. I think kind of mapping sensitivity, so that's the percentage of kids that are picked up, versus specificity, which is the kids that don't actually have the condition that are kind of also picked up incidentally. It's a good reminder that where we set the cut point sort of kind of leads to sort of that combination, and there's sort of certain value that's put on putting that where we set that cut point. So are we looking for high sensitivity to be really confident that the kids that we're identifying are very likely to have autism? Is it better to find a balance? That's still something that we're grappling with. But we feel that that the AOC is kind of comparable enough to sort of diagnostic measures, and particularly the ADOS at 18 months, that it's worth exploring whether both in a predictive context and even in a diagnostic context in that age group that it might be worthwhile to kind of consider it part of the toolbox. I do want to emphasize that even as prospective studies have sort of pulled away from parent stories and kind of focused more on lab-based measures, observational measures, technology-based measures, that parent stories are actually incredibly informative, including early in life. I think that the field had placed less emphasis and we shifted to sort of the sibling approach, kind of just recognizing that learning in real time could provide added value. But parents' stories also offer a lot of value in prospective studies. So asking parents to talk about their observations and concerns sort of at the time as they first emerge, rather than sort of, when the child's referred at age 4 or 5 and asking them what their children was like at a year. Independently coding sort of these parents' kind of interviews and stories, we actually found that there were quite distinct differences in the rate of concerns expressed by parents of infants who went on to a diagnosis of autism, both related to sensory differences as well as motor differences. And inspired by that, we actually, with Susan, developed a questionnaire version of our observational scale. And it was important to find that even though our kind of so-called trained eyes weren't really picking up on a lot of differences before a year, if you allowed parents to describe sort of their impressions at 6 and 9 months, they were describing features that were actually specific to autism. Back and forth vocalization, sort of a range of differences at 9 months. It seemed that parents were sort of kind of, they were about 3 months ahead of us in terms of sort of recognizing those differences. I'll talk briefly about advances in biomarkers as well as kind of technology-based assessment. These slides come from the infant brain imaging study led by Joe Piven. I've had a role sort of in supporting the behavioral assessment. It's just an illustration of how measurement that's not specifically related to behavioral features of autism can still provide sort of a prediction of sort of the infants most likely to develop autism. So Heather Hazlitt's paper from 2017 sort of looked at brain imaging, so MRI scans at several points in time. And she found that, that increased brain surface area in the first year preceded kind of rapid brain growth, which is what we tend to associate it with autism later in life. And that using kind of machine learning approaches, that the prediction of these kind of brain imaging indices was actually quite impressive and in some respects sort of more predictive than some of the early behavioral measures. Similarly, indices of functional connectivity, again using machine learning approaches, kind of where the functional indices separated the children diagnosed with autism at 2 based on sort of their imaging in the first year quite remarkably well. And then again, I think as Aubin alluded to, there's a lot of really important work looking at sort of whether technology-based measures and specifically, so the use of sort of kind of computers to kind of quantify some of these behavioral features that we're using sort of our clinical eyes or relying on parent report, there's tremendous possibility to be more precise about picking up potential differences and also the possibility to make these kinds of measures a bit more accessible because they could be accessed sort of outside of an academic center. They might even be able to be embedded in an app. And exciting developments. I mean, I had a great meeting with some of the trainees that work at the Mind Institute earlier, and we had a discussion that we have to consider all of these as tools and not sort of a replacement for expertise, for parent stories and what we observe, but it may very well be value add. I'll briefly mention the social ABCs. I mean, just to emphasize that that there is more at stake to early detection than just characterizing early features and sort of moving the age of diagnosis earlier. We genuinely can offer something. So Sally Rogers' work with the Early Start Denver model and now Infant Start has really led the field in terms of demonstrating that that identifying early features provides an opportunity to connect families with a knowledgeable therapist and an evidence-based program. This is another example of a manualized program sort of falling broadly within that group of interventions that Ahmed described as the naturalistic developmental behavioral interventions. Developed by Jessica Bryan and Susan Bryson. One of the specific features of this intervention is that it's entirely a parent coaching model. So the interventionist does not actually sort of demonstrate the skills or work directly with the infants, but rather sort of kind of supports the parent through learning the specific skills and then sort of provides kind of real-time feedback to help them refine their approaches. It's a relatively low-intensive model, and in contrast to the Early Start Denver model, it's not a comprehensive model of intervention, but rather focuses specifically on directed vocal communication as well as sharing positive affect, kind of directed smiles. And you know, inspired by the work with the Early Start Denver model, Jess has really taken this work from an initial clinical trial demonstrating that parents were able to master these skills over a relatively short period of time, and that there was a strong relationship between fidelity and the benefits that were experienced by the infants, sort of on both of the targets. Here showed shared smiling, but similar effects for directed vocalization. And it's followed an evolution that I think both our early intervention as well as our early detection work needs to follow. To start with a rigorous study under controlled settings for intervention with kind of well-designed clinical trials, And then to sort of move out from the academic center into the community and sort of look at ways of spreading and scaling the intervention, retaining the integrity and continuing to evaluate in new contexts, sort of using clinical trial methodology, but ensuring that we can continue to sort of make the intervention sort of more and more widely available. I'm proud that this intervention has been adopted by one of our provinces in Canada. It happens to be the smallest province, but it's a start, but also in local areas. But I'll acknowledge that sort of even with its kind of child and family focus, that there's still some discomfort in some circles talking about intervention, the notion of intervention and sort of modifying behavior early in life. So that's kind of the main part of the presentation, but this is kind of the director's cut. So I feel like I'm kind of showing you my best data, but I have to say that what I've learned from, the two big things that I've learned from this infant SIB work. So first, one I talked about, and that was like diversity. So it looks a lot neater if you kind of group all the autistic kids together in terms of demonstrating those group differences. But we all know in terms of early detection and diagnosis, it's with an individual child. So we actually need to be much more attentive to individual differences. I think along those lines, the second thing that I've learned from being involved in this work is humility. We very naively started these projects thinking that if we only spent enough time with families and we got a lot of practice with these assessment measures, that we would be diagnosing all the kids by 18 months or 2 years. And it's only because of a lack of knowledge that we're not able to do so. So kind of fast forward, it hasn't quite played out that way. So I'll share a couple studies just to illustrate that. So previously I showed the AOC scores based on grouping the autistic kids and the non-autistic kids. So if one takes kind of an agnostic statistical approach, just looking for the natural grouping in the total scores over time, like a lot of this kind of trajectories research, you get multiple groups. The smallest group are the ones that have this inclining trajectory. So they start with somewhat higher scores, and they do actually have a modest increase over time. There's a larger group that have, is this me? No, that's right, sorry. There's a larger group that have an intermediate level of scores and they don't really change over time. And then really the largest group are the group that sort of have relatively low scores and they stay low over time. So I'd like you to imagine for a moment how the autistic kids are distributed among these trajectories. Wouldn't life be easier clinically if they were all sort of within this inclining trajectory? So we would know what to look for, the signs would be more distinctive, and we could even potentially sort of identify them, very early in life. So not surprisingly, among that inclining trajectory, the majority of those children did end up being diagnosed with autism. But if you look at the total group of children diagnosed with autism, they were relatively evenly distributed among those trajectories, including a substantial number that were actually in the low trajectory, where, by extension, it's unlikely that the AOC would have been helpful in terms of identifying the early signs in the first 18 months. I think the second line of research, and I want to acknowledge Sally's work with the Baby SIB Consortium, kind of looking at the sort of changes in diagnosis over time. When we looked at our own experience, at that point, we were just under 400 children that were followed to age 3. Most of the related work done in the clinical field was about stability. So this idea that if you saw a child at age 2 and you made a diagnosis, would they still have the diagnosis at age 3? And sort of most studies said, categorically, yes. There were very few kids that would move off the spectrum. We sort of set it at rest and sort of were confident in our ability to do autism diagnostic assessments kind of in young preschoolers. However, and we kind of replicated that. It's true. If we made a clinical diagnosis at 18 months or 24 months, it was very unlikely that those children would not meet criteria when assessed independently at 3. However, we actually diagnosed about only half of the kids at age 2 that were subsequently diagnosed at age 3. And there's a really distinctive pattern. So I've separated out all the autistic kids sort of based on whether they were first diagnosed at 18 months, 24 months, or 3 years. And this is what they were like at the age of 2. So the kids diagnosed at 18 months or 24 months invariably had some degree of developmental delay. So this is the Mullen here. It's a T-score. So it's kind of like a standard score, except a T-score of 50 is sort of like kind of that average. So, 35 is like 1.5 standard deviations below average, 40 is 1 standard deviation below average, and so on. So invariably, delays kind of both on direct assessment of development as well as parent report of general day-to-day adaptive skills. The kids that were not diagnosed at 2 but were subsequently diagnosed at 3 as a group did not have developmental delays and really across the board and quite significant differences. And interestingly, even though there was some degree of delay in day-to-day skills that parents were picking up on, they were sort of broadly within a standard deviation, so not necessarily standing out as developmentally delayed. And on sort of our kind of gold standard measure of autistic symptoms at age 3, the ADOS, there was also a difference even at age 2. Those of you who are ADOS aficionados will recognize that this comparison score of 4 is kind of right at the cut point. So there were definitely children who had, kind of significant sort of autistic features on the ADOS at 2, but were not diagnosed. So the question is, well, why did we not diagnose them? I think the reason was that there was sufficient ambiguity, both for the parents as well as the clinicians, that we felt like we didn't quite have enough information. And it really sort of speaks to that gap. And again, that relationship between specificity and sensitivity and how we calibrate our sort of clinical decision making. We can be more inclusive, but we're likely to include kids that we're genuinely not confident about and perhaps will not kind of ultimately have autism. So there is this group that has autistic features, but that we were not diagnosing at age 2. So I just no longer like the word unstable. It just seems so inappropriate to be calling these kids are not unstable, even or even sort of this idea of misclassification or false negatives. These kids, based on a gold standard assessment, did not meet criteria. We actually accept for other diagnoses like ADHD that the child doesn't necessarily meet criteria for the diagnosis sort of from infancy. So it seems likely that this is not simply a lack of knowledge or expertise, whether in our clinics or frankly in the community, but a reflection of the diversity of early development. And there may be opportunities to recalibrate and diagnose earlier and earlier, but there may be this period of ambiguity that we need to continue to grapple with. So it's not just a lack of knowledge in the community, like even the so-called experts were not making these diagnoses. I think there are a couple important clinical takeaways. I mean, one is that, especially in a strained system, it can never be that families have one opportunity for a diagnostic assessment. I think we, again, have to recognize our limitations and the limitations of our assessment process and keep an open mind and an open door. So just to end the presentation, I want to kind of circle back to the earlier point that although we can celebrate the advances in knowledge about early signs and sort of how we've pushed the envelope, not only with behavioral features, but sort of what we're learning about biology, genetics, imaging, sort of computer-aided assessment. When my colleagues and I sort of developed the kind of practice statements for the Canadian Pediatric Society about early assessment, we reviewed the literature. I think it's changed a lot since then. The age of diagnosis has not changed all that much, sort of in the 20, 25 years of this baby SIB work, and largely is at the age, on the average is sort of around 4 or 4.5. So as we try to shift our ability to detect features from 2 to 18 months to a year, there are many kids that are not sort of making their way to an autism assessment until sort of even after until after they're in the school system. I think we've had this assumption that there will be this indirect effect on age of diagnosis based on becoming sort of more able to identify earlier and earlier features. But that it's really not sort of played out that way. And I think that when we speak to families and clinicians, they'll say, our knowledge is not the bottleneck in the system. The bottleneck in the system is that we don't actually have enough specialized assessments to offer in order to kind of respond to parents' concerns and clinical referrals. So at the same time as we're doing this infant research, we really need to think about sort of innovating at a health system level, sort of kind of breaking the mold and sort of revisiting sort of how we approach assessment, sort of thinking about sort of not blaming our community colleagues, but rather thinking about how to empower them and sort of bringing them to a state of advanced practice that they can sort of be more active participants in the diagnostic process. And at the same time as we're doing that, thinking about how we can make access more equitable and sort of recognizing our failures in that way in terms of kind of groups of individuals in the community who based on ethnicity or geography are not benefiting from advances in the field. The Canadian Pediatric Society guidelines, as well as other international guidelines, are increasingly embracing the notion that it should not be a one-size-fits-all approach. There can be multiple pathways to diagnosis that are different than our traditional center-based kind of multidisciplinary assessment. Multidisciplinary can be it can be at the same time, or it can occur in series. We can sort of work together and communicate so that we're not necessarily having to sort of have everything kind of completely consolidated into a single assessment. These are pathways, but they're not silos, so that there has to be flexibility to shift from a community assessment to a kind of a more specialized assessment when there's uncertainty. I think this kind of shift generally reflects sort of where our thinking is at. Talking to colleagues who are still getting ill, it's like, I think the pandemic is officially over. I think we're still dealing with infectious disease that's sort of like dramatically transformed sort of how we do assessment. Masking on, masking off. I think that it may not be that we're quite post-pandemic, but I do think having to respond to the public health measures and the clinical constraints of the pandemic made us a bit more open-minded and a bit more cognizant of some of the flaws in the system that kind of came to the surface because we weren't able to operate business as usual. There is good data now that community assessment shows strong agreement with specialty assessment. This is a study from a colleague in Toronto, Mel Penner, who looked at community pediatrician assessments of children who are independently seen by a center-based multidisciplinary team. The overall agreement rate was 76%. Not surprisingly, the kids with more subtle features, there tended to be more disagreement, but it wasn't that meant that it led to an inaccurate diagnosis, but rather because the community pediatrician recognized that they weren't certain, they had an opportunity to then refer in. There are different continuing education models that can support this process. ECHO Autism, and I know there's an amazing ECHO project here as well. It's such a great acronym, but this particular one is for Extension for Community Health Outcomes. It really is a process for creating a telehealth community-based community of practice, sort of inviting community clinicians to present kids that they're seeing, kind of draw on their colleagues' expertise to ask questions and provide recommendations. It can be used for sort of ongoing continuing care, but also sort of as an add-on to kind of focused diagnostic training, and recognizing that all of us as clinicians kind of learn and become more confident over time, and that's going to be true for community clinicians as well. And I think it's sort of part of a broader shift from thinking about autistic kids as a kind of a small group that need to be seen in a specialty clinic to thinking about autistic people as a segment of society that need health care from the point of detection, diagnosis, and then ongoing care. And building on that relationship with the community professional, even through the diagnostic process, sets the stage for ongoing continuity of care. At our center, we've sort of had an approach where, we've done some initial traditional training in person. A colleague and I then go to the pediatrician's office to actually sit in with them and sort of provide coaching and feedback in the moment. And then they use that ECHO platform to discuss the kids that they're seeing to kind of fine tune and be ready to go. the kind of both through personal experience and more recently a qualitative analysis of sort of pediatricians' feedback about what it's like to participate in this. I think about my department head role and sort of how busy my colleagues are. And it seems like a smart idea for autism specialists to be sharing some of the responsibility for diagnosis, but a lot of other pediatric specialists have had this smart idea as well. So community pediatricians have been inundated with requests and expectations to kind of provide that advanced practice role. But there is at least a subgroup of pediatricians that are so passionate about this area and are really just looking for opportunities for continuing education and support, and then running with it. The thing that they tell us gets in the way is less their knowledge of assessment and assessment tools, and more how they integrate this into their busy practices. And I think that's where the broader community partnerships to support families accessing resources, kind of providing emotional support and subsequent navigation makes a difference. And even technical things like sort of refining report templates to just make it a bit faster to generate, and then sort of continuing to fine tune. And this sense of an ongoing community of practice, and it does help to have a local champion, whether that's kind of an experienced pediatrician, family doctor, nurse practitioner, and increasingly autistic health professionals who do draw on their living experience to really sort of talk about sort of how important this work is. So just some final thoughts. We've started with early detection and diagnosis. I think sort of recognizing the diversity of autism, that even as we continue to improve our ability to identify and diagnose, we need to recognize that this is work that needs to take place across the lifespan, and we need to increasingly think about timely diagnosis, timely responding to concerns as they emerge, and timely in terms of making sure that the individual and family can quickly work through the system to access the assessment that they need. As we're building that capacity, we need to make sure that it doesn't reinforce disparities that exist in the system, and sort of acknowledge that there are going to be diverse needs and it's require some flexibility. One topic that'll be great to talk about as a panel is how do we rapidly expand the capacity that we need while not compromising the integrity of the process or undermining the confidence of the decision makers that are responsible for eligibility for service funding. And again, a lot of us work in a pediatric space. If you talk to adolescents and autistic adults, it's a bit of a wasteland in terms of publicly funded assessment, and we need to make sure that our work doesn't stop at age 3, age 8, or age 18, but making sure that we're working with our colleagues to build a system of care for autistic adults as well. So again, thank you for this amazing opportunity. So looking forward to your questions in the panel discussion. Thank you.
The difference between Sally's original paper and the number of girls that are diagnosed through InfantSib versus the 2-to-1 ratio now, what is the difference there, do you think, that's happening in terms of picking up more girls?
Yeah, it's a great question. There was another paper that came out recently. The first author was Meng-Chuang Lai, talking specifically about the disparities in the system for autistic girls and women, and including around early detection. And I think a number of people have sort of done analyses looking at there are genuine differences in some of the earliest features in terms of kind of more sort of age-appropriate interests, sort of greater subtleties in terms of social presentation. I think that the Baby SIB consortium as a whole has gained experience seeing these really young girls, and I think increasingly is narrowing the gap. I think that what is the true sex ratio, I think we're still learning. What was I going to say? So the other relevant work in this area is our group compared the 2- and 3-year-old girls that were diagnosed kind of through our InfantSib study, and then the 2- and 3-year-old girls that participated in another longitudinal study of autistic children that were diagnosed through the clinic, kind of what we called an inception cohort, in that all children diagnosed in a particular clinic over a period of time were invited to participate. The main difference was that the girls that were identified through the SIB study tend to have milder features, including less severe language delay and less severe cognitive delay. So that disparity in terms of age of diagnosis is true across girls and boys, but particularly for girls. It's on one hand, there are such strengths in terms of sort of having more advanced language and cognitive skills, but it may lead to clinicians, both because of bias and genuine difficulty because of subtlety, under identifying them. So that seems to be the group of girls that is being added to the SIB group and that is not being identified in the community.
This is a quick question I have. I have a lengthier one for later. But this has to do with the motor delay in the SIBs that you're talking about and in everybody's studies who found these motor delays. And it's interesting to me that I haven't seen a paper very much that looks at differential diagnosis of later intellectual disability coexisting with autism, and to what extent that intellectual disability, or more general developmental delay, as I'm going to say it, is part of the motor delay as opposed to part of the specific ASD constellation.
Yeah.
Can you answer that question?
Yeah, it's a great question. I mean, we need to look at that more closely in our data set, but I do think that if you look at H3, the group of kids that also have more severe developmental delay, if not intellectual delay, are more likely to have those motor features. I think what your question also speaks to is the caution about generalizing our findings from younger SIBs to the general population, because the truth is, in part because of the way participants are invited to participate. In general, the families where the older autistic child had a specific genetic condition were excluded from participating, and therefore the rates of intellectual disability, including in the consortium-wide studies, are actually pretty low. So, the differential diagnosis among siblings and the sort of the spectrum and relative rates of outcomes is actually quite different in siblings versus kind of in a community cohort that might be referred for early assessment of social concerns.
The UC Davis Mind Institute was founded in 1998 with the promise to reduce and prevent the disabilities that can be associated with autism and other neurodevelopmental conditions. Every day, our clinicians and researchers make progress on that promise. Our groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other conditions associated with disability are helping affected individuals achieve their fullest potential. Please visit our website or our social media platforms to find out more about current studies, upcoming events, and how you can help make a difference.